we want to increase HDL, which is a good cholesterol, but we want to decrease other lipoproteins like LDL, VLDL, and triglycerides. So we want to correct the dyslipidemia. That's why the drugs are called anti-dyslipidemic. The most important drugs in this category are called statins. Now, first of all, we'll discuss how these statins work. Liver is the major organ in which cholesterol is synthesized. So how liver synthesized cholesterol is? There is a compound called HMG-CoA. This is converted to mevalonate. The enzyme involved is HMG-CoA reductase. This is the rate limiting enzyme in formation of cholesterol. The mevalonate is then converted into cholesterol. So statins are the drugs which act by inhibiting this enzyme HMG-CoA reductase. So when HMG-CoA reductase is inhibited, cholesterol will not be produced in the liver. Now when cholesterol is not produced by liver, so there will be deficiency of cholesterol. Liver has to form many hormones, many vitamins and many substances by using cholesterol. As liver is not able to produce cholesterol, so what it does is it will increase the number of LDL receptors on its surface. So after some days, number of LDL receptors increase on the surface of liver. LDL receptors increase. When the LDL receptors increase, they will pick up the cholesterol from the blood. So the cholesterol present in the blood will be picked up by liver. The liver can utilize this cholesterol to form its essential substances. But as the cholesterol decrease in the blood, it will result in its anti-dyslipidemic effects. So statins, they inhibit HMG-CoA reductase, which will lead to compensatory increase in LDL receptors on the surface of liver. So that will take up the cholesterol from the blood. Now the drugs in this statin group are, we have atorvastatin, rosuvastatin, pravastatin, simvastatin, fluvastatin, serivastatin, pitavastatin. So these are some of the important statins. Now one thing which you need to read carefully, there are some more drugs also which end with statin, but they are not anti-dyslipidemic drugs. Like we have a drug called as cilastatin, which is used along with imipenem, which is an antimicrobial drug. We have another drug called pentostatin, which is an anti-cancer drug. We have a hormone called somatostatin. You must have heard about this hormone. So that means all the drugs which end with statin are not HMG-CoA reductase inhibitors. So MCQ asked is, all of the following are HMG-CoA reductase inhibitors except, and they will give all 4 statins in the option. So you need to identify which statin is actually a statin and which statin is not a statin. So that you can answer if you look at the name of statins carefully. So all these statins, if you see carefully, before the statin, the name contains Va. So remember, statin is a statin only if it is vastatin. If it is not ending with vastatin, it is not a statin. Like this is a lastatin, this is a tostatin. So it must be ending with vastatin. Now important points regarding statins to remember. Statins have maximum LDL cholesterol lowering potential. Maximum LDL cholesterol is decreased by statins. Second, statins, they are usually given in late evening or at night time. The reason is HMG-CoA reductase has maximum activity at night. So we will like to give statins at that time when their concentration is highest, when the enzyme is highest. So they are given in late evening or night. However, certain statins, particularly atorvastatin, and rosuvastatin, they are very long acting statins, so they can be given at any time of the day, and rosuvastatin is the longest acting statin. The major adverse effects of statins are myopathy and hepatotoxicity. Statins can cause myopathy and hepatotoxicity. The risk of myopathy, it further increases if statins are combined with fibrate group of drugs. Fibrates are also anti-dyslipidemic drugs, but when statins and fibrates are combined together, risk of myopathy increases. Recent finding is that statins increase the risk of diabetes mellitus. Statins increase the risk of development of diabetes mellitus. Now, apart from their dyslipidemic effect, anti-dyslipidemic effects, statins have some more beneficial effect on the heart, which are called as pleiotropic effects. Pleiotropic effects. So these are the extra benefits of statins apart from cholesterol lowering potential. These effects include plaque stabilization, they decrease endothelial dysfunction, they also decrease inflammation. These have anti-inflammatory effects. These also decrease oxidative stress. These also have anti-thrombotic effect. Anti-thrombotic effects. So these effects are called pleiotropic effects. They also benefit the cardiovascular system. And these effects you can remember from the name pleiotropic effects. So pleiotropic effects include PL means plaque stabilization. Plaque stabilization. E means decrease in endothelial dysfunction. I means decrease in inflammation. O means decrease in oxidative stress. And TR means decrease in thrombosis. So these are pleiotropic effects of statins. So now moving to important points regarding the individual drugs. Simvastatin and lovastatin, these are pro-drugs. They are not active, they are pro-drugs. Second, these have maximum CNS penetration. Among all these statins, maximum CNS penetration is with simvastatin and lovastatin. Then we have a drug called pravastatin. Pravastatin, the special points to remember. 1. Pravastatin is very little metabolized by CYP3A4 enzymes. Remember, most of these statins are metabolized by CYP3A4. So pravastatin has negligible metabolism by this enzyme. So it is less prone to drug interactions. All other statins, when we combine with CYP3A4 inhibitors like erythromycin, ketoconazole, they increase the risk of myopathy because their metabolism stops, plasma concentration increase, that can result in myopathy. But the risk of myopathy is very less with pravastatin. Myopathy risk is very less, and one major reason is it is not metabolized by microsomal enzymes. Second thing, it has very less interaction with meal, food. Most of these statins, the food increase the absorption, but pravastatin food do not increase the absorption. So it can be given with meals or without meals. There will not be much difference. Clear? So these are the important points regarding the first group of hypolipidemic drugs, which are statins. Now moving to second group, it is called ezetimibe. Ezetimibe. This is a drug which acts by inhibiting the absorption of cholesterol from the GIT. In the GIT, there is a transporter known as Niemann-Pick like 1 C1. a protein or a transporter is present in the GIT. The name is Niemann-Pick like 1C1. So this transporter help in absorption of cholesterol from the intestine. So ezetimibe inhibit this transporter. So cholesterol cannot be absorbed. So when cholesterol is not absorbed, the blood cholesterol will decrease. The basic concept here is our body has very strong compensatory mechanisms. When we give statins, the liver is not able to form cholesterol because HMG-CoA reductase is inhibited. So when liver is not able to form, then this transporter Niemann-Pick like 1C1, it is overexpressed. Upregulation occurs, so that means more cholesterol from the diet can be absorbed now. Similarly, when we give ezetimibe, then this transporter is inhibited. So that means cholesterol cannot be absorbed. When cholesterol cannot be absorbed, now there is upregulation of HMG-CoA reductase on the liver. So liver will start synthesizing more cholesterol. So basically, if we give only statins, the tolerance can occur because of more absorption from the GIT. If we give only ezetimibe, then tolerance can occur because of more synthesis by the liver. But if we combine the two, then these compensatory mechanisms cannot occur. So ezetimibe is formed to combine with the statins so that tolerance do not occur to statins. Okay. Third group of anti-dyslipidemic drugs are fibrates. Examples of fibrates include clofibrate, fenofibrate, bezafibrate, and gemfibrozil. Now fibrates, they act by stimulating a receptor called PPAR alpha, peroxisome proliferator activated receptor alpha. Stimulation of this receptor result in increased synthesis of lipoprotein lipase, and when more lipoprotein lipase is produced, that will metabolize the lipoproteins, so that will lead to decrease in triglycerides. So fibrates have maximum triglyceride lowering potential. Just like statins have maximum LDL cholesterol lowering potential, fibrates have maximum triglyceride lowering potential. We already discussed if fibrates are combined with statins, there is increased risk of myopathy. Next group of anti-dyslipidemic drugs is bile acid binding agents. Bile acid binding agents. These are called BABA drugs, bile acid binding agents. The examples of these drugs include cholestyramine, cholestyramine, and cholecalciferol. Cholestyramine, cholestyramine, and cholecalciferol. From the name you can remember, their names start with chole, and we know chole is related to bile. Cholelithiasis, cholecystitis. So similarly, the drugs whose names start with chole, they are related to bile. So they are called bile acid binding agents. Now how these drugs work are, this is our GIT, this is liver, this is our gallbladder. The bile is drained through the gallbladder into the duodenum through the bile duct. Now when we eat food, so many fat soluble substances, these are transported with the help of bile acids. So bile acids, they are produced by the gallbladder. Through the bile duct, bile acids come here. So bile acid will bind to this substance, and after binding to this substance is absorbed into the blood. So bile acid bring the substance into the blood. After reaching the blood, bile acids, they will leave the substance in the blood. and then the bile acid is again secreted into the gallbladder. Bile acid is again secreted into the gallbladder. So bile acid will again go into the intestine, bring another substance, leave it into the blood, and again bile acid will be secreted in the gallbladder. This type of circulation is called as enterohepatic cycling. Entero means intestine, hepatic means liver. So the substance is going from the intestine to liver to intestine to the liver. Enterohepatic cycling. So in simple language, if you want to understand, the bile acid, they are acting as a taxi driver. So what they do is they park their taxi here. These foods which we are eating, they act as a passenger. So they will bring the passenger in the taxi into their destination. So blood is their destination. They will leave the passenger in the blood, and again they will be secreted into the gallbladder, and again they will park their taxi. They will bring another passenger, and in this manner they will keep on working. Now when we give a drug like cholestyramine, which is a bile acid binding agent, so that will bind to bile acid instead of the normal substance which we want to absorb. So now the bile acid binding agent or the drug has bound to the bile acids. So when the drug binds to the bile acid, it cannot be absorbed, and this bile acid will be excreted. So when the bile acid goes out, there will be deficiency of bile acids in the liver. So now the liver will start converting its cholesterol to bile acids. So when the liver start forming bile acids from the cholesterol in the liver decreases. So finally we want to decrease cholesterol. So cholesterol is decreased because that is consumed in conversion to bile acids. Now special point about bile acid binding agents, or the main advantage of these drugs, is they are not absorbed at all. They act in the GIT, bind to bile acid, and they are excreted. So when they do not come into the circulation, so they will not cause major side effects. So the main advantage is these are very, very safe drugs. So they are drug of choice for dyslipidemia in children and pregnancy. Bile acid binding agents are drug of choice in children and pregnancy. The major disadvantage of these drugs is their palatability. Particularly cholestyramine and cholestyramine, we need to dissolve them overnight in the water, and then we have to take in the morning. So it is very difficult. Whereas cholecalciferol is a new drug which is in the form of tablet, so it can be taken directly also. The next group of anti-dyslipidemic drug is niacin. Niacin is nothing but vitamin B3. The major points regarding niacin is, number one, it has maximum HDL cholesterol increasing property. Highest HDL cholesterol increasing property is with niacin. Second, this is the only drug which can decrease lipoprotein A. Lipoprotein A is highly atherogenic lipoprotein, and niacin is the only drug which can decrease this. And another important thing, niacin is vitamin B3, which is very cheap. So it is the least expensive drug, very cheap drug. So in spite of all these advantages, niacin is not commonly used. The reason is niacin causes side effects like pruritus, means itching, and flushing. These are the compliance limiting side effects of niacin. So if we give niacin to any person, mostly they will stop taking after a few days because of pruritus and flushing. These adverse effects of flushing and itching, they are assumed to be due to release of prostaglandin D2. So that means if we inhibit the formation of prostaglandin D2, then we can stop these side effects. And the drug which can decrease the formation of prostaglandins is, yes, aspirin. So aspirin can be used to decrease the flushing and itching due to niacin. Recently we have developed one more drug which is prostaglandin D2 antagonist. It inhibits the PGD2 receptors, and that drug is called as laropiprant. Laropiprant, as the name tells, it is P means prostaglandin, PR means prostaglandin, ANT means antagonist. It is prostaglandin D2 antagonist and it is given by ORAL, oral route. So prostaglandin antagonist which can be given orally is lyropiprant. It is specifically indicated for niacin induced flushing or itching because it will block the action of PGD2, so can be used to decrease flushing and itching. Apart from these compliance limiting side effects, niacin has some other side effects also. The important ones include hyperuricemia. This is the most commonly asked question in the exams. Which hypolipidemic drug cause hyperuricemia or which can precipitate gout? The answer is niacin. Apart from hyperuricemia, niacin can cause liver damage, hepatotoxicity also. And one more important side effect is it can cause insulin resistance. So niacin is not given in diabetic patients because it can result in insulin resistance. So these are the important points regarding the niacin. Okay. So now we will move to some new hypolipidemic drugs, new drugs in this category. So first group is a drug which target the PCSK9. First of all, what is PCSK9? PCSK9, the full form is pre-protein converting subtilisin caxin type 9. So what does it do? So if we try to understand, we discussed that the LDL receptors, they are present on the surface of the liver. So LDL receptors, they will bind to LDL and take up in the liver. If we make the diagram, so this is our liver, this is the blood. So LDL receptors which are present here, their function is to take the LDL from the blood. This is LDL. So they will bind to LDL and take up in the liver. So that's why in the blood LDL will decrease. Now what happens further is after binding to LDL and going inside the liver, LDL receptors will leave the LDL cholesterol here. And now this receptor, the LDL receptor which has gone inside the liver, now it bind to PCSK9. So PCSK9 which we were discussing, PCSK9, now this bind to the LDL receptors and now it will take this LDL receptor to the lysosomes. So this LDL receptor is taken inside the lysosomes and now the lysosomes will break this LDL receptors. So basically PCSK9, it help in breakdown of LDL receptors. So if we inhibit this PCSK9, then LDL receptors will not be broken. When more LDL receptors are present, they can take up the cholesterol from the blood. So we can use the drug as hypolipidemic drug. Okay? So the drugs which inhibit PCSK9, they can be used as hypolipidemic drugs. And the drugs are, there are two types of drugs. One which inhibit the formation of PCSK9, PCSK9 formation inhibitor. And second which is a monoclonal antibody against PCSK9. So two type of drugs we have formed. One, drugs inhibiting formation, and second, drugs which are monoclonal antibody. The drug which inhibit the formation is inclisiran. Basically, what is inclisiran is, it is a small molecule inhibitor of RNA. It has chemical structure similar to RNA of PCSK9. So it will interfere with the transcription of the PCSK9 protein. So the name says it is small molecule inhibitor of RNA. Small molecule inhibitor of RNA. It inhibits the formation of PCSK9. On the other hand, we have some monoclonal antibodies against PCSK9. These are alirocumab and evolocumab. Alirocumab and evolocumab, these are monoclonal antibodies against PCSK9. So all these three drugs, they will basically inhibit the action of PCSK9. So LDL receptors cannot be broken. So when their level increases, they will take the cholesterol from the blood. So they are used in homozygous hypercholesterolemia. Okay. Then moving to second drug, we have a drug which target the MTP inhibitor. First of all, what is MTP? The full form is microsomal triglyceride transport protein. Microsomal triglyceride transport protein. What does this protein do is, in our liver, we know in the liver, whatever excessive cholesterol is present, it will be packed in VLDL. So VLDL contains cholesterol and triglycerides. So triglycerides are packed in the VLDL with the help of this protein known as microsomal triglyceride transport protein. The name says it will transport the triglycerides into VLDL, and then this VLDL will come into blood. So if we inhibit MTP, simply we are inhibiting the formation of VLDL. So when VLDL is not produced, then LDL will not be produced. So we can decrease the cholesterol. So simply it inhibits the formation of VLDL. And the drug which inhibits this protein MTP is lometepide. Lometepide. It inhibits MTP. The name itself says MTP inhibitor. Lometepide is MTP inhibitor. Second new drugs in hypercholesterolemia. Then we have third group of drugs. This is drug known as mipomersen. Mipomersen. So what this drug is, basically it is an antisense oligonucleotide. Antisense oligonucleotide. Remember, any antisense oligonucleotide, the name says the chemical structure is similar to antisense strand of RNA. Okay? So RSEN, their name end with RSEN, RNA, R means RNA, sense means antisense oligonucleotide. So any drug ending with RSEN is antisense oligonucleotide. So mipomersen is antisense oligonucleotide against ApoB100. So remember, whatever apolipoproteins contain ApoB100 like VLDL, LDL, so they will not be formed by mipomersen. So mipomersen is antisense oligonucleotide against ApoB100, inhibit the formation of VLDL, LDL, etc. Clear? Then lastly, we have drugs called as CETP inhibitors. CETP. The full form is cholesterol ester triglyceride transport protein. Now before going to the drugs, we'll try to understand the basic thing. This is our liver. These are the peripheral tissues, maybe muscle, adipose tissue, other areas, and this is the blood. We know LDL etc. when they are excessive in the blood, they can form the thrombus. Atherosclerosis can happen, so they will deposit in the blood vessel, and this LDL is taken up by the liver so that thrombus do not occur. So LDL is a bad cholesterol, it can deposit in the blood vessels. Yeah. But on the other hand, HDL we know are a good cholesterol. So what liver does is, liver will form HDL, which is called as a nascent HDL. So it will leave this HDL in the blood. The function of HDL will be to take up the cholesterol from the peripheral tissues. So it will take up the cholesterol from the peripheral tissues and then it will bring it back into the liver. So this is called as a reverse cholesterol transport. Normally LDL cholesterol can deposit in the tissues, blood vessels and other tissues. So whereas HDL will take up this cholesterol and will bring it back into the liver. Now what happens when HDL has taken up the cholesterol from the peripheral tissues? Now in between VLDL, LDL etc. it will meet them, and these VLDL and LDL, they say that let's do an exchange program. Let's do an exchange program means they will say that you take up our triglycerides and give us the cholesterol ester. So VLDL and LDL, they try to exchange the cholesterol ester of the HDL with the triglyceride present in them. So this is with the help of an enzyme known as CETP, cholesterol ester triglyceride transport protein. As the name says, cholesterol ester and triglyceride will be exchanged. Now if this happens, then the cholesterol which it has taken from the peripheral tissues, it will again go into LDL, and that LDL can again deposit in the blood vessels. So we do not want this, otherwise cholesterol will again go into blood vessels. So what we have done is we have developed a drug which inhibit this CETP. So when we inhibit CETP, then HDL will not go in exchange its program, and then HDL will increase, and when HDL increases, that we can protect from the atherosclerosis. So basically the drug inhibiting CETP, it will act by increasing HDL, and the drug is anacetrapib. Anacetrapib, it is CETP inhibitor. Again, from the name you can remember, name contains CETP inhibitor. CETP inhibitor, anacetrapib. Clear? So these are the important points regarding the anti-dyslipidemic drugs. Okay.